Thank you so much for joining us here today. My name is Jen Lyle. I'm the CEO of the Alzheimer's Society BC. And today's events, we're going to be having a conversation that matters, or more specifically, conversations that matter. This one today is about medical assistance in dying, also known as MAiD, a BC healthcare provider perspective. Before we jump in, though, I want to first acknowledge that the Alzheimer's Society BC operates on the traditional, ancestral, and unceded territories of Indigenous peoples around the province. Our provincial office is located on the territories of the Musqueam, Squamish, and Tsleil-Waututh, with regional resource centers located on traditional territories in all regions of BC. Now, our vision is a world without Alzheimer's disease and other dementias, and that world begins with a more dementia-friendly society, where people affected by dementia are acknowledged, supported, and included. And this vision is only possible through ensuring that everyone living on these territories has access to support that is culturally safe and barrier-free. So it's great to see so many of you joining us from around the province today. So again, today we're discussing a deeply personal issue, medical assistance in dying, also known as MAiD. Now, end-of-life care is complex. People living with dementia and caregivers have varying opinions, experiences, and feelings about the topic. We're here to provide people living with dementia with the support and information so that you can make an informed decision about your care and end-of-life options that are right for you, and to support you in making your wishes known. We have resources to help assist with personal planning. So if you come away from today's webinar with questions around advanced care planning or anything else related to dementia, please don't hesitate to call the first link, Dementia Helpline, for information or support. So we are joined here today by our panelists, Barb Pesut, the Principal Research Chair in Palliative and End-of-Life Care at UBC Okanagan. Welcome, Barb. And also Laurel Plewes, Director of Vancouver Coastal Health's Assisted Dying Program. So welcome to you both. Now, Barb and Laurel each see the issue through a different lens, as a researcher and as a healthcare practitioner. So we're grateful to have both of them with us here today. And I'll also preface today's discussion with, this won't be the only conversation we have on this topic. In fact, we will be hosting another upcoming discussion on MAiD, featuring a different group of experts, people living with dementia. That webinar will focus on their personal insights and reflections around medical assistance in dying. And this is in keeping with our commitment to ensure that people living with dementia, their caregivers and family members are included in discussions, decisions, and policies that affect them, including things like medical assistance in dying. These events follow our first webinar last fall on dementia and medical assistance in dying, which featured Dr. Dirk Coetzee, a practitioner of medical assistance in dying. You can find links to this, along with other previously recorded or upcoming webinars at alzheimerbc.org. So that's alzheimerbc.org. So please watch Dr. Coetzee's talk if you're interested in learning more about MAiD and dementia. He covers a lot. And of course, if you have questions or comments during the webinar this afternoon, please feel free to use the chat box throughout the event. When you're asking a question, we just ask that you please set your message to go to panelists only, and you will remain anonymous. We'll move into the Q&A just past the bottom of the hour. Now, to kick off the discussion, Laurel, I'm going to go to you first. Are you able to tell us a little bit about the current MAiD eligibility criteria and how it relates to someone living with dementia who might wish to access MAiD?
Absolutely. So I'll start off with the easy ones, and then I'll get into the more technical ones. So first off, someone needs to be at least 18 years of age. They need to be able to access funded healthcare within Canada. So within British Columbia, they need to have access to funded MSP. And then they also need to be applying for MAiD after have been informed of all the means available to alleviate their suffering, including palliative care. And they have to also provide informed consent. So they have to be capable of providing consent while they're being assessed. And I can talk about the nuances of that if you like. Then the last bit, which is the part that has some interpretation from care providers, is they need to have a grievous and irremediable medical condition, which means that they need to have a disease, illness, or disability. They need to be in an advanced state of irreversible decline and capability. And that's not capability in terms of decision-making, that's capability in terms of activities of daily living. Are you able to do the things you could do 6 months ago? What does that decline look like for you? And the last one is they need to be experiencing intolerable suffering that's intolerable to the person and cannot be relieved by any means that the person deems acceptable. And when we're talking about suffering, that's both physical or psychological suffering. So even if you have a diagnosis of chronic pain, but you're experiencing a psychological impact of that, then that is still potentially something where you can be considered eligible. So anybody with those instances can apply, except for those with a sole diagnosis of a mental disorder. And we've heard multiple times from Minister Lametti, who is the Minister of Justice, that dementias are not considered a mental disorder. And so right now, since 2016, up until now, those with Alzheimer's have been able to apply and have received an assisted death. So I'll stop there unless you have any specific questions that you want me to ask about dementia.
Thank you, Laurel. No, that's really helpful. And I think it's good for us to just have a basic grounding in terms of where the legislation's at right now. We've seen, of course, medical assistants in dying in the news. So I think it's great you've provided a nice overview about where we are right now in terms of the landscape. So thank you. I'd like to shift gears now and talk a little bit more about your programs and your respective research. And so, Barb, I'm going to start with you. I'd like you to share with us a little bit about your program area, your area of research. So, Barb, over to you.
You bet. First of all, thank you for the opportunity to be here today. I know Laurel and I are both just delighted. So we are really interested in quality healthcare systems. So, MAiD has been particularly contentious, I think, over time. If you followed the media flow recently, there's been quite a bit of contention around different things. And so we're really interested in really showing the robustness of our healthcare system and seeking out the areas that need improvement. And so to ensure there's just really the highest quality care for clients, for families, for the healthcare providers really that take part. And so we decided to actually take the angle of lens from nurses, because nurses have actually quite a privileged position in our healthcare system. So they work with people over time. They work with people quite closely. They get to see people in long-term care, in acute care, in community. So they see people across the context. And so then they have actually quite an insider view on system issues. Nurses actually kind of have this panorama view that when you think about it, very few people in the system have. And they're often our leaders in our, major institutions. So we decided we were going to interview nurses. And so we've been funded actually by CIHR for a couple of studies, and we're following nurses in particular longitudinally. So we started our interviews in 2018, shortly after the legislation, to get a sense of their experiences and their ideas about health system improvement, what was working well, what wasn't working well. Then we did a second set of interviews in 2021. And now we're in our third round. And so I think we've completed probably 130 interviews of nurses and nurse practitioners from across Canada. We've really tried to look at the full geographic scope, including urban and rural. And so it's been a fascinating journey to see from their perspective how things have changed.
Thank you for sharing that, Barb. And I know we're going to dig into some of your findings in a little bit. So we'll come back. We'll leave that as sort of a cliffhanger, a trailer, if you will. We'll come back to that. Laurel, for you, in your role as the director of this program in Vancouver Coastal Health, why don't you tell me a little bit more about what your role is?
Sure, absolutely. And so I'm a nurse by background as well. So that's interesting to hear that a lot of our nurses are part of the leadership. So I'm an example. My role grew quite organically. Initially, it was just me trying to understand what the health authority needed to understand how we could support people through the assisted dying process. And what we found out is, like Barb mentioned, there are some people that don't necessarily want to be involved. So we decided we needed to create some kind of care coordination service. And so my job has been to create that care coordination service, understand what needs to be there, and identifies both systemic barriers, both within the health authority and within the province, to help since MAiD is new, figure out where we're hitting with previously established systems and help understand how we can bring that down in order to make sure the MAiD is more accessible. So we have care coordinators, and then I work with all the MAiD providers and also with the staff and medical staff throughout the health authority in all the different care areas providing MAiD, and then also work with leadership to help roll out education plans, update strategies and policies, and then work with the province to help understand how we can ensure MAiD is easily accessible to those that want it.
Well, thank you for sharing that, Laurel. And it's a nice segue in many ways to my next question, which really starts to get into the meat of things, which is around how nurses experience being involved in MAiD. Now, in our last discussion, just to provide some context to people who are listening in today, our last discussion on MAiD really focused on sort of the physician's perspective when it comes to that. So today, I'd like to dig into a little bit more around how nurses in BC experience being involved in MAiD. And Laurel, I'd like to start with you. I mean, what's it like for you, and maybe how has it changed over time?
Yeah, it's been interesting watching and feeling out what we feel was necessary. So I originally started as a clinical nurse specialist, and then I brought on a care coordinator who was a nurse. And at that time, there was a couple roles that you could do early on in MAiD, which hasn't really changed. So we have our care coordinators that help people and their families go through this process from start to finish, or if they don't want to proceed with MAiD, they still follow them along until either their natural death or they withdraw. Then we have support nurses that go out to the person's home or wherever that person is, insert the IV, and support the patient and family through the process. And then we also have nurse practitioners who were the first country in the world that allowed nurse practitioners to assess and determine eligibility and also provide MAiD. So that's pretty special. And so those are the three that we've seen in terms of our program. But then if I didn't talk about the nurses at the bedside, that would be a big miss. Those nurses are really the ones that help the patient and family through the day-to-day decision-making. Is this what I want? Is this not what I want? And understanding and talking with the family about what that means for them. And I'm planning about, the nurses don't help, they don't plan specifically when the day is, but they are a sounding board for that person about what that suffering feels like for them. And when for that person might it be a good time for them to proceed with MAiD. So it's, I think that there are other nurses roles that we could identify, but those are the ones that currently exist within BC.
Thank you for that, Laurel. And what I'm hearing too is there's even been an evolution in terms of the different roles that we've seen across the nursing profession as we learn more about the process and also as the legislation evolves. Yeah. Barb, you mentioned this in your earlier comments around the nature of the research that you do, but I'd like to dig into that a little bit more around what have you learned? What have you learned about how nurses experience MAiD through your role as someone who studies palliative and end-of-life care?
Yeah, it's been really such an interesting journey for me because, I think I find that so many nurses say that this is so well suited to what nurses do. And so I've had to reflect on that a lot. And I think it's partly because nurses tend to be very relational beings. They go into nursing because they like to work with people, they like to be coaches and advocates, and they also tend to be fairly compassionate and probably deeply attuned to suffering. And so one of the things that nurses have talked about over and over again in our interviews is what it's like to work as a nurse over time alongside people who really suffer, whether that be people coming into the emergency department or the intensive care unit or people living in long-term care. And they talk very often about the vicarious suffering that nurses feel as they walk along clients and family who are suffering. And for many of those, particularly those that work in end of life care, I think sometimes there's been a bit of a frustration as well with a lack of ability to alleviate some of that suffering. And that might be because some of the treatments they're experiencing are suffering inducing in and of themselves. It might just be the nature of the illness that they're struggling with. And so nurses really talk about how rewarding and meaningful it is to actually be able to address people's suffering in a way that gives them choice over, over the way that they live and die. And so many find that very meaningful. They like being the coaches and the advocates that Laurel talked about. The fact that they're able to work with clients and families over time, helping them to know what to prepare, helping them to kind of set aside those special rituals that might go along with the MAiD death. And so doing all of that sort of advocacy coaching work that nurses really do very well. Having said that, it's also very challenging. It's very emotionally labor intensive work. So nurses talk a lot about the need for a very high degree of self-care and being very reflective about where they're at in the work and how they're feeling about it, and the kind of circumstances that are feeling a bit much for them. And of course, it goes without saying that there are some nurses for whom this just isn't their picture of nursing or palliative and end of life care. And those are your nurses who are conscientious objectors. And I think we think that this whole process really doesn't touch them, and yet that's a very deep misunderstanding. It does. From our research, we know that these nurses often still stay very involved with clients and families, and they may step out at the end if this is an option that they just personally don't feel comfortable with, but they still journey with patients and families, and so they may feel a bit differently about it than those nurses who find it incredibly meaningful. But it's really that compassionate perspective that really unites them all, depending on how they feel about this as a choice.
Well, thanks for that, Barb. And the other thing that I'm hearing as well is just how much the role of being the advocate and the supporter of someone in making their wishes known, in walking their path, how intrinsic that is to the nursing profession, period. And what I'm hearing too is there's that tension that exists around, how do I have my own self-care? What if the decisions the client is making, the person I'm working or walking alongside with, what if their decisions differ from what I personally value? So thank you so much for providing that perspective. And we'll have a chance to dig into that a little bit more. I also want to put a friendly reminder out there for anybody who has questions. Please don't hesitate to put them into the chat box. You don't have to wait to the very end. We'll have a couple more questions to go, and then we'll go right to the audience. So Barb, I want to follow up with you, because one of the things that both you and Laurel have talked about is that concept of communication, being able to understand what people's wishes are and support them in making those decisions. So let's talk about what you've learned about the challenges of communicating wishes for MAiD. So Barb, I'll go to you first.
I know Laurel, as a frontline provider, probably has a rich experience. So I'll touch upon it briefly, and then I'll send it her way. But it's so true. So first of all, one of the communication challenges is a bit of a misperception in the public about MAiD. First of all, about what it is. It is not withdrawing treatment. It's not withholding treatment. And I find that there's just a fair bit of confusion out there around, what MAiD is. And the other thing I hear fairly commonly is this idea, this fear that MAiD is something that can be done to you without, your choice and your fully informed choice, and something that you express over and over and over again. So I think there is a fair bit of public misunderstanding around what it is and how it is that, you come to make that choice. And I'm sure Laura will talk about that as well. But I think the really important piece that I kind of want to settle on is the really importance of making your wishes known, and not just about MAiD, but about all of your end of life decision making and how important that is. Because I think oftentimes people don't realize how much choice they have in the process. I mean, we refer to this as advanced care planning. So that idea that you sit down and you think about what's really important to my quality of life as I get older and as my health declines. What treatment would I like to have? What treatment would I not like to have? And you'll notice there's been, I believe, what's a bit of a miscommunication in the media recently. And it's the miscommunication that healthcare providers are trying to push MAiD by bringing up the conversation. And if anything, it's exactly the opposite of that. It's healthcare providers very purposefully introducing the option early on with people, long before they get to the point where MAiD is something that is an option for them so that they can make their wishes known, and so that healthcare providers know whether this is something that fits within your value system or it doesn't. And they want to bring it up at a time when you're not vulnerable, at a time when you can sit back and think about that and think about how that fits with your values. And so I think there's been a fair bit of miscommunication in the media in particular around what that conversation is all about. The third thing and last thing I want to say before I kind of turn it to Laurel is just because somebody expresses a wish to die, it doesn't necessarily mean that they want MAiD. And I think that's very, very important. If you work within palliative care for any period of time, you know that that discouragement that comes during that process, many people will make some reference to the idea that they're done, or, you know, they're tired and I just wish this was all over. It doesn't necessarily mean an express wish for MAiD. And so one of the roles of nurses, and Laurel in particular, and I'm sure she'll talk about this, is really discerning what is it you're saying in that communication? What is it that's really important to you and you need and you want? And so the more that people can get comfortable with having these conversations, thinking about what's important to them, talking to their families about that, their physicians about that, that's all really, really important in this process.
Oh, thanks for that, Barb. And Laurel, I'm watching you enthusiastically nod your head at a couple points here. So same question over to you, Laurel. Like, what are some of the challenges that you've encountered around just that communication piece, and how do you navigate it?
Yeah. And thank you, Barb, for so articulately describing a lot of the things that we do experience. There's a lot of things you said that I very much thank you for describing. I think the thing in terms of communication, people are afraid of MAiD. They think that we're coming in and we're doing not good things. If someone hears about it and they say, "Oh my gosh, you can't do that." I think what I'd like people to understand in terms of what MAiD is, it's really a goals of care conversation. Our MAiD providers come in, they talk to people about what would you like what has happened to you, what do you see your next few months, years look like, and where does MAiD fit? And so we do find that when we have that open communication with patients and with their families, that patients say, "Oh, I didn't know that I could die at home," or "I didn't know that that resource existed." And so I think that MAiD's while that may not be the best way for them to get to that resource, going through this really arduous process of applying for MAiD, I'm grateful that they have had the option to apply for MAiD, because maybe they wouldn't have had the information about ways that they could support the way that they want to die in the future. So that has been a really effective means of us communicating what else is out there to make sure that this isn't the last resort, that people understand what services they do have. And so then they can make those decisions with their families. What Barb mentioned about families is really, really important. We're finding that a lot of people feel like either their care team will judge them if they're applying for MAiD, or their family will judge them if they're applying for MAiD. And so a lot of what we try to do is understand with people, what's that perception? Can you tell us what that's from? And then really work with the people to understand, like, this would be the impact if you didn't tell them that you were going to apply for MAiD. Could we really talk about what that would be? What would that mean for you? What could that mean for them? Because we know that if people find out that their loved one had MAiD and they weren't necessarily involved, then that could feel really awful. So it's really something that we hold dear. Is we really want to make sure that all the people that could be aware are aware, while still maintaining patient-directed confidentiality.
Well, thank you for sharing that perspective, Laura. And what I'm reflecting on, both what you and Barb brought up, is really it's that values-based conversation that nurses are having with the person in their care around what matters to you. And I'm reflecting on the title of today's webinar, which is literally Conversations That Matter. But what could be more important than making your wishes known around how you want to live your life? And most importantly, how you want to live your life towards the end of your life. So I think that's what I'm taking away from both of you, is just how critical that communication is, and both exploring from a values-based perspective people's options and ensuring that they know what those options are to the fullest extent. So I very much appreciate your comments there. I know that we've got some questions that have already started to pop up in the chat box. Please continue to put them in there. We're almost there. So make sure that we have time to get to your questions. I want to go back to a comment that you both made earlier around the one of the criterion for MAiD is suffering. And so my question is, with suffering being an essential eligibility criterion for MAiD, what's the difference between how we may traditionally think about suffering and what we're talking about when MAiD is involved? And how does that definition fit with what you've actually seen? So Laurel, I'm going to go to you first with that question.
Well, this is such a tricky one. And it does differ by practitioner. So for the people that are assessing MAiD, some have a different determination about how they determine suffering. But what's written in the law is, and that's what we try to stick with in the program, is that it's the patient telling you that they're suffering. And it's their determination of suffering that is the thing that matters. And if someone says that they're suffering, just like if people say they're in pain, we believe them, and then we go from there. We have had lots of people who are said, I'm not currently suffering, but part of my suffering is anticipating suffering. So then that's a really complex conversation that the MAiD providers have to talk through and understand, and try to figure out, are there any things that can address their suffering now? Or not. So it's very individual. I wouldn't say that there's one way to assess suffering. It really has to be taken on a case by case basis. And that can change, as people may say, when I'm suffering here, then that's when I want to have MAiD. But then they get there and it's not what they thought it was going to be, and then they shift. And so then their version of what they think could be intolerable suffering may differ as they go through their journey. And so our job is just to be there and present with them and listen to them and how they feel suffering is for them. And then they tell us if it's time.
I appreciate your points there, Laurel. And I started nodding too around people's perception of what constitutes suffering changes as they go along the journey. And as you rightly pointed out, and I think there's a parallel to our work when it comes to dementia. Sometimes people's perception of what a future state looks like with regards to dementia is actually different and changes as they progress, because you get a better sense of, hey, yeah, I can actually have a good quality of life. So again, what I'm taking away from that is really the importance of ongoing dialogue and having those values-based conversations. So thank you so much for bringing that up. Barb, same question over to you.
Yeah, so when we interviewed the first round of nurses, I think many of them were very surprised by the nature of suffering that they were confronting with MAiD. I think many of them expected physical suffering, and they expected to see uncontrolled pain and sort of that type of suffering that they could actually see. And of course, the way the safeguards in the law were set up, that just didn't work, right? People had to be of sound mind to make a decision. You didn't want them suffering in that way, because that in itself, is not a time when you want people making such a momentous decision. And there was a 10-day waiting period. And so, you didn't want to wait until people were in that kind of suffering. And so I think initially for nurses, it was a little bit disconcerting. So those that would come and assist, they would find people that looked in their mind relatively well. They might even be answering the door in preparation for MAiD. And so I think initially there was some misunderstanding from a nursing perspective, but then it's been very, very consistent over the MAiD reports that have been published. All 3 years that have been published now have said really the primary reasons for suffering are not that, uncontrolled pain, but it's like fully 86% is related to the loss of suffering of not being able to engage in meaningful activities or to do the types of day-to-day things that they would normally do, or as Laurel talked about, that anticipated suffering, that anticipated pain. And so we're really learning that the nature of the suffering is actually a little bit different than what we thought initially. And that's really important, because one of the things that people talk about a lot is, well, if we just had more palliative care, then we wouldn't have that type of suffering. And I think we really need to think carefully about those claims. And I'm not saying that palliative care doesn't do a marvelous job alleviating suffering. They do. They're remarkable. Palliative care can avert all kinds, but there's a suffering that comes with anticipated death and the losses that go with that that, I think we often have to think, are those really treatable in the traditional sense? I mean, I remember a palliative friend said to me once, there's just sometimes a hard work that goes with dying, a hard emotional labor that goes with giving up those things. And so that's often the types of reasons that you'll see that people will apply for that. And I think the other thing to really remember, and Laurel alluded to this so well, is that people who work as assessors and providers and as clinicians, they bring their own suffering experiences as well. And oftentimes when you see really fierce MAiD advocates, you will look into their background a little bit, or you'll ask them about their own story, and they will tell you a profoundly story of suffering from their own background that has really convinced them that this is a choice that people need to have. And so it really is central in terms of what we're doing here.
Oh, thanks for that, Barb. And I'm keeping an eye on some questions. And actually, I have a question that's for you because it touches on the points that you just raised. And I was struck by your comment around how we, my words, not necessarily yours, but how we bring our own history and lens to our perspective and our experiences. And so one of the questions that I have is ultimately, no one can force a healthcare provider to provide MAiD. Like that is a choice for healthcare providers to participate in that. So from your perspective or your research, what factors influence healthcare providers when they make that choice?
Yeah, there are many, many. So, I think first of all, it's their own family experience. And so, whether that be just the culture within their family and about whether there's religious prohibitions against MAiD or not, it's also about healthcare providers' own emotional resilience in the face of doing such difficult work. So conscientious objection actually isn't always about, I believe this is right or wrong, but it's about people's very candid self-assessment as well as to whether this is work that they can do. And we have a number of examples in our research data where nurses thought that this was something they really wanted to be engaged with. And the compassion that was required to be involved in the work was so much that they found it taking over their lives. So they would ruminate day and night around cases. They could tell you exactly how many they did. The memories were indelibly there, and ultimately they felt that they just couldn't engage in that work over time. Other factors that go in is sometimes even if people aren't necessarily comfortable with doing it, if there are compelling reasons in their community where they think it needs to be done, then they'll often step up to the plate. So that may be rural and remote communities where everybody else has said no, but a nurse practitioner might step up and say, this wasn't really the direction I saw my career going, but there's nobody else to do this, and this is something that we need to do, and so I'm going to do this. Whether they feel comfortable with the support that's around them in terms of a team, and whether they just feel comfortable in terms of their own competency. So there are a multitude of factors that go into that decision. And I think, again, this is one of those that we tend to paint as black and white. You either believe this is a good thing or not morally. And the picture is just so much more complicated than that. And everybody kind of needs to do their own reflection around those factors and whether this is a role for them.
Oh, thank you for that, Barbara. And Laurel, I saw you nodding your head there. I don't know if you wanted to add any of your thoughts from your perspective.
We do, when we bring on support nurses, so those are the ones that go out to people's homes, we have about 50% of the people that stay after they've gone through the preceptorship, and then 50% that don't. So what Barb's saying is it borne out in real life, that people, they think it's really important, but then they just can't. The other last thing I'll say is that some people could be, a bedside nurse could be really supportive of one patient because of XYZ, but then it comes to another patient and they're very not supportive because of ABC. And so I wouldn't say that someone's a conscientious objector across the board. You can be a conscientious objector for one patient and very much support the other patient. So it's very changeable, and nurses are growing through this process just like everyone else.
Thanks for that, Laurel. And I'm noting there's a couple questions that have come through the chat around sort of this idea of making your wishes known in advance. So there's a couple comments that have questions around specifically the waiver of final consent, but there's also one where people are wondering, like, can I make a statement in my will or something to that effect? So Laurel, curious for you to run us through the nuances on that one, because I know they're different.
Yes, absolutely. So let me do the waiver of final consent first, and then I'll talk about advance request. Yeah, that's probably the right way. So the waiver of final consent is for people that have gone through the eligibility criteria process, and they are potentially at risk of someone that could lose the ability to provide consent. And so this waiver of final consent was put in because of someone named Audrey Parker. She had a fear that she was going to lose capacity to allow for her to have MAiD. And so she had an assisted death 2 months earlier than she wanted to, because she wanted to have an assisted death on her. I can't remember what event it was, but she wanted to die on a certain day, but she wasn't allowed. She didn't feel like she could because she was afraid she would lose capacity. So then the government created this waiver of final consent, which can be used, and it's an agreement between the patient and the MAiD provider. So this can't be transitioned to another MAiD provider. It has to be, you can only have a waiver between two people. You can have a waiver with multiple care providers, but the only person who can enact the waiver is the physician or nurse practitioner that's written on the waiver, which I think is important to remember. You can't just come in and do it if you haven't already assessed the patient and had a waiver. A lot of people, how does the waiver work? So this, again, is a little bit different based on the practitioner. So if you are going to get a waiver, it's important that you have a conversation with your MAiD provider to understand how they want to enact the waiver. But if you, like we talked about with people, they feel like their suffering is going to be too much here, but then when they get to that point, then they want to move their assisted death to a later date. So you do, as the waiver, you need to have a date in mind when you would like to have an assisted death. As people with dementia, the MAiD providers ask them to just pick a date so that we can make sure that they are covered in case they do lose capacity. So then if that date comes and the person still is of sound mind and does not want to have an assisted death, which is completely fine, then they can rewrite another waiver. And so if you had two practitioners with two different waivers, you need to do that twice, but then you can keep moving the waiver along. What we did before we had the waiver is with people that had dementia or with people that we felt like had fluctuating capacity, we would speak with them on a regular basis. So the MAiD provider would have a conversation with that person to say, how are you doing? I feel like I should probably connect with you in about 3 months. And then as that person's capacity ability changed, then they maybe increased the frequency of connection to make sure that they were catching that person's desire for MAiD at the point that they wanted it. So we want to make sure that this is driven by the person and that they're saying when they want to have it, as opposed to what's written on a piece of paper. And then in the end, if that person doesn't want to have an assisted death and the waiver has expired, then we aren't able to provide MAiD. But if that's what that person wanted, then that's what that person wanted. So then, okay, now we'll talk about advanced. Should I stop there and see if people want to? Or
yeah, no, that's great too, and I can see kind of where you're going, because I think, and I'll just say too, like for people who are interested in understanding the nuances around waiver, final consent, and advance requests, Dr. Coetsia's webinar is really helpful as well. But appreciate you walking us through that, Laurel. One of the other questions related to this idea of advance requests, and I know that's something that's been under consideration with the federal government presently. Why don't you walk us through right now where that sits?
Sure. So there isn't legislation right now where someone who hasn't been assessed for MAiD could write in a document, I would like to have MAiD if X happens. And then that be a lawful thing that a physician or nurse practitioner could do. So there would need to be a change in legislation to allow that. There has been a special joint committee release that came out a month ago now that said that that joint committee advises the government to put in legislation to address advance requests within the next 5 years. Senator Wallen is a very passionate senator that would really desiring to see advance requests put into legislation. So I think that we will see it in the next 5 years. And how we operationalize that is going to be different than actually getting it in. So I don't have words for you about what you could potentially write in your will, but I do know that a lot of people are meeting with their lawyers and writing it into their will, but that may not be legal if it comes to pass. So right now it's not legal, but I think that it will be at some point.
Yeah, thanks for that, Laurel. And I appreciate that from a healthcare practitioner, that actually opens up some additional questions, some additional ethical quandaries, so to speak. Just a friendly reminder, thank you to people who have put their questions already in the chat box. So this is great. Please keep them going. I got another one here, and Barb, I'm going to direct this one to you first and then over to you, Laurel, because Barb, you talked about it in the context of why healthcare providers may choose to go into MAiD, in the context of I'm a rural healthcare provider and I'm the only person in my community who can do it. So let's talk about gaps. First of all, are there any gaps or areas for improvement in the delivery of MAiD in BC? So for example, rural and remote communities. Are there challenges around access to MAiD practitioners?
Mm-hmm. Yeah, so from our current round of research, so we've just begun the next round again. There are certainly some gaps, and I think actually probably one of the biggest gaps are supportive teams. So if you work in, urban Vancouver, urban Toronto, all of the urban areas, you're often surrounded by a team of practitioners. So you'll have physicians, you'll have nurses, sometimes social workers, spiritual care providers, there's regular debriefing, there's all kinds of support as you grapple with different assessments and things that are going on, family support. But you think about a nurse practitioner doing this alone in a rural and remote community. So they can certainly reach out distance-wise for advice around particularly difficult assessments. But we have heard a lot of angst from our research participants when they need to work alone and do this very difficult work. So I think that's one gap. The other gap that I think we need to fill in many areas, and I always say this very tentatively because we're 10 provinces and 3 territories, and it's almost like 13 different countries, right? And so when you interview in Ontario, you're going to see something very different than Newfoundland, than, it's just all over the map. But there are still, I think, major areas of Canada where there are not good systems put into place to support this. And when I mean systems, I mean, funding to support the people that need to do the work. And this is particularly important with C7, where we have the more complicated patient or clients for whom death is not reasonably foreseeable, right? Whose natural death. And now with the potential of people whose sole underlying medical condition is a mental disorder, these cases really, really take time. And so you think about a really robust healthcare system that can do this job well. It requires people in the system who can work with these applicants over time, dig out information that they need, have a long series of conversations, and that really means a system. And it's going to mean a system, too, that may be different than the palliative system. So in some ways, our systems across Canada, in many ways, the palliative and the MAiD systems work hand in hand because of who our original clients were under C14. But now that's changing. And so we need to rethink our systems. We need to rethink what resources are required to do all of this well.
Oh, thanks for sharing your insight on that, Barb. And I think we all appreciate how this is a rapidly evolving area in many ways. Laurel, I'd be curious to hear your thoughts around, and maybe I'll frame it a little bit differently, but what sort of improvements do you or maybe your colleagues see are needed to meet the needs of BC families when it comes to end-of-life care and in particular MAiD?
I think we're seeing a lot of issues right now with service provision. So like within British Columbia and across Canada, we need to work on maintaining a consistent group of people that are actually going to be able to provide care. So we don't have closures, or we don't have people not able to get home care services because that care isn't necessary. So, and that goes along with MAiD, where we don't want MAiD to be used because people couldn't get home care services. We want MAiD to be used when people have the optimal care available to them. Otherwise, we are put in a spot where we don't feel, we're not quite sure, are you coerced into doing this? Is this a decision that you actually would like to make, or is this a decision that you're making because of something else? So that's a really tricky thing that we would love for there to be a fully funded and fully staffed healthcare system in order to make our lives a little bit easier, and for the people that we're serving. so that they feel like they're making this choice freely. The other thing I think we need to do better and understand more is the impact of MAiD for family members and caregivers that are supporting people through the process. I think that we have been really focusing on making sure that people get what they want, and we have been impacting people maybe unnecessarily. And so I think I need to do more in understanding what that means for people that are going through the process and what kind of supports they need throughout the process and after, if their loved one does have an assisted death. And then the last one is recruitment and retention into our own teams. We need to, like Barb said, we need to probably create some better resiliency systems to make sure that people do feel able to stay within the profession of MAiD, to make sure that they're not leaving because it is too much. And what does that look like, and how could we improve? So those are three. I could go on forever, but those are my top three.
No, I appreciate you sharing that, Laurel. And I think that's why part of what having conversations like these are so important, so that we can identify some of these things and bring them to daylight, so to speak. So thank you very much for sharing that. And I do want to, again, plug the opportunity for our audience to participate via the chat box. So please do keep your questions coming. We've got time for a couple more, so take advantage of the fact that we've got two experts on the call today that we can who we can direct questions to. So please do continue to do so. I have another question for you, and we've touched on this already, and I want to delve into it a little bit more deeply. And Barb, I'm going to start with you. We've heard from some people that just knowing that MAiD is an option for them offers almost like that sense of relief from fear of suffering. And you talked about that anticipatory aspect of the dying process. Has this been your experience, or can you speak to this idea? Has that borne out in your research?
Oh, yes. Nurses talk about this a lot. And so it's not even, it's funny, it starts with the application process. It's not even the official assessment, but it's this idea that somebody is listening to my story. Because you know what, I think things probably get pretty challenging by the time people apply for MAiD. And I think we don't really realize that. We don't talk about that. It can be a very, very tough step for people to do. And so here they are presenting, and a compassionate person on the other end of the line, like Laurel, who says, "Tell me your story, right? Tell me what it's been like for you. Tell me what has prompted this call." And so even that interest shown by healthcare of hearing people's suffering stories and those gentle inquiries around, have you looked into this? Do you know that this is available? And so all of that kind of goes into that, even just preliminary conversation, even before we get to assessment. And then I know from interviewing multiple nurses about how they conduct those assessments, there's this really very blunt language. So they're very blunt with people around what this is all about, but a very gentle approach in terms of assuring people that they can go through this step and don't have to go any further. And that at any point in time, just because they do this, they are not obligated to do anything. And so you're right, there are just so many people that have what they feel is like this piece of control in their back pocket. And a nurse who works with them over time, like Laurel alluded to, checking back with them on a continuing basis. How are you doing? Where are we at now? How are you feeling? And it's done in such a gentle way. It's not like, okay, we're ready for this now. It's like, how are you doing? I'm just touching base to see how you're doing, and I think it's that relational based care that really ensures that people that go forward are really, really certain that they want to go forward. And that all their concerns about a system that might drop them, or things that, or just not being able to find this or that when things get a bit more difficult, they have that assurance. And so we hear many, many stories about the role that it can play, just having an assessment and knowing it's an option, even if you never want to use it.
No, thank you for that, Barb. And one of the words that you used was like that piece of control, because I think one of the things that we hear often about is when you get that initial diagnosis of dementia, there's this feeling of a loss of control. And so much about having a good quality of life is feeling like you have a say in your life, that you have purpose, and to your point, that you're surrounded by people you feel are listening to you and are seeking to understand what's important to you. Laurel, I'd be really curious to get your perspective on this when it talks about, so going back to the original question, has it been your experience around when people go into the MAiD process, it's almost like starting that process in and of itself is a form of relief?
Absolutely. Yeah, we definitely see it. And I think it's, in multiple ways. I think one way is that it brings families in, because maybe that person didn't want to describe their suffering to their family, but now they've admitted that they want MAiD, and then families want to say, tell me why, like, why would you like this? I want to understand. And so then there's a lot of relief from that person that their family then understands, and then maybe there's additional support or things happen because of the request for MAiD. And another thing is that we're just another team now that's hearing them, and we have open ears, we're listening. And so if they want to tell us something about what happened over here, we're here to listen, and then we can advocate. Like, we're a consulting service, we don't become these people's primary care provider, but we can at least hear them if they say something else isn't going right, because we have had that before as well. So I think just knowing that there's other people that are listening, that they can tell us their story, and again, opening communication and talking about what that feels like in and of itself is a relief. 50% of our patients that apply go through with MAiD. And so I think that in and of itself says that just because you apply for MAiD, it does not mean you're going to go through with an assisted death.
Yeah, thank you for that. And I know we're almost getting close to the end of the time. I know we had some other questions around eligibility. Just to reiterate Laurel's earlier point, you have to be the age of majority in order to apply for MAiD. So minors can't apply for MAiD at this point in time. Although that was some of the work being done at the legislative level. I appreciate everybody else's questions. And again, if you do have questions more broadly around just the current process, highly recommend Dr. Coetzee's webinar. We'll make sure that that link is available. But again, you can just go to alzheimerbc.org and look for our recorded webinars. I can see that it's going into the chat right now too, so that's great. And I'm so sorry we weren't able to get to all the questions, so I appreciate everybody sharing them. I'm going to leave it at this last one though, and this will be for both you, Barb, and you, Laurel. What's one thing you want people to take away from today's webinar? So Barb, I'll start with you.
Oh, that is such a good question. I would say the most important thing is to be curious and to not buy into the incredible polarization that happens in this debate. So every time that you see something in the media, be curious around what the other side of that might be, because I think we've become very polarized. And so this idea of being curious, of listening, of developing a deeper understanding would probably be my main message for today.
Thank you for that, Barb. Laurel.
Yeah, along with Barb, it would be like talk to the professionals and talk to, because each health authority has a MAiD care coordination center. And so if you have a question about MAiD, contact that MAiD care coordination center. There's lots of myths out there that good people are perpetuating because they think that that's the truth. So if you want to understand what's actually accurate and legal, please contact them.
Thank you, Laurel. And I know that there were a couple questions we weren't able to get to that were more specific. So if somebody has a specific question about themselves or a family member, they can contact their local coordination. Perfect. Awesome. So again, thank you to you both for joining us here today. Thank you, everybody, for taking the time to join us for this conversation. And also thank you for your questions in the chat box. And again, if you have additional questions, please don't hesitate to reach out. If you have questions more generally around end-of-life planning or advanced care planning, we're here to help through the dementia helpline as well. So please don't hesitate to reach out. And if you have questions or a concern that hasn't been addressed today, please don't hesitate to email us at advocacy@alzheimerbc.org. So that's advocacy@alzheimerbc.org, and we'll be happy to follow up I also mentioned the First Link Dementia Helpline, great resource for everybody. So once again, thank you very much to Barb. Thank you to Laurel. Thank you to our ASL interpreters, with Joy and Jess. Thank you so much. And we hope to see you at our next conversation that matters.